So I'm one of the neurosurgeons in Beaumont, and I also work in Temporal, do pediatrics there. This little princess on your screen is one of our patients. Her mum has kindly agreed for me to show her picture in public. I'll just talk about her operation and her outcome right at the very end. So, epilepsy surgery. It's a huge topic. I apologise if I'm going to show some graphic pictures. It's very hard and to explain neurosurgery without showing them. It's all about technique, approaches, operations, scans. So I hope you don't get taken back by it. So as Norman and David said, epilepsy affects 1% of the population. It poses a huge economic strain and also a challenge to resources available. So why surgery? Why do we go on and do these operations? Well, 2/3 of patients are controlled at 5 years on medication. However, it leaves 1/3 of patients who have medically refractive epilepsy. And as Norman alluded to, this is a huge problem, and not least the significant side effects associated with it. There's a big report in the Journal of Neurology last summer which computed the 2-year mortality rate from drug-resistant epilepsy, and people kind of skirt around this in medical circles, but the 2-year mortality rate from drug-resistant epilepsy is actually 12%. So that's not to be underestimated at all, I'm afraid. And that's the drive of people like Norman and his fantastic team in Beaumont, is to push people forward for operations who are drug-resistant, who are truly drug-resistant, and we all work together in the epilepsy surgery program. So you can see the slide with regard to success with anti-epilepsy drug regimes. The majority are seizure-free with the first anticonvulsant, but you can see as you introduce successive anticonvulsants or more and more anticonvulsants, the chance of becoming seizure-free becomes less. And you can see the big 36% of people who are not seizure-free. So why treat medically refractive epilepsy? Norman and Dave touched on this earlier. Recurring seizures do damage the brain. In children, frequent seizures interfere with normal maturation of the brain. This may result in cognitive and behavioural patterns, attention deficit disorders, hyperactivity and aggressive behaviour, sudden death, psychological limitations in adulthood, and the so-called phenomenon of kindling, meaning secondary foci being developed with chronic epilepsy. So as a rule of thumb, and it's a particular point that Norman always makes at our group, is that if epilepsy isn't controlled at a period of 2 years with well-known and well-described anticonvulsant regimes, well, that patient should be considered for surgical, or at least the evaluation with regard to surgery. We've all come across patients who've had, epilepsy cases or epilepsy syndromes who've had persistent seizures for many, many years, and who should have been referred for surgery at an earlier time. And so it's important to understand that if drugs are going to work in a particular epilepsy patient, they're going to, and if the correct drugs have been prescribed, they should have worked within that 2-year period. And if they don't, people need to be moved on. 2 years is enough in terms of trying to get a grip with things. And that is the fact, and Norman always quotes this: 4% of patients with medically intractable epilepsy are controlled at 5 years on medication. So it's terrible if you see people who are put onto another drug and another clinic visit a year's time. So the surgery for epilepsy, it all revolves around the identification of the epileptogenic zone. The epileptogenic zone could be a thumbnail of tissue right in the motor strip or in front of the motor strip, or it could indeed be the whole cerebral hemisphere. So it depends on where the seizures are coming from. Just as a general, very broad classification with regard to epilepsy surgery, we deal with focal epilepsy, meaning seizures coming from one area. We also operate on cases with generalized epilepsy, meaning multifocal epilepsy, or epilepsy coming from various areas. So it's a huge surgical distinction. The majority of epilepsy surgery is done for focal epilepsy. And we use these terms like the epileptogenic lesion, seizure onset zone, etc. So what is the scope of epilepsy surgery? So we can resect epileptogenic lesions in the temporal lobe, of which we do quite a lot, extratemporal, meaning the frontal lobe, occipital lobe, parietal lobe, or indeed we could do a hemispheric resection such as a hemispherectomy or hemispherectomy for diffuse conditions. We can limit seizure propagation by cutting that tract of tissue which crosses from one side of the brain to the other, which is the corpus callosum. We frequently do that in cases who've got bifrontal epilepsy, and they get a rapid spread of seizures from one frontal lobe to the other. And they get drop attacks, and they fall and they hit their head, and so on. So in order to stop that rapid propagation of seizures, we can cut the anterior 2/3 of the corpus callosum, which doesn't abolish the seizure onset area, but it certainly limits its rapid spread. We can do fancy operations around the motor strip called subpial transections. I'll come on to that later. And we can also do vagal nerve stimulation. So I wonder if I may just run through all of these techniques. With regard to this pre-surgical evaluation, folks like Norman and his great group look at the seizure semiology. The seizure semiology is basically the clinical manifestation of the particular seizure. So patients with a video EEG monitoring, they have EEG recordings, but they also have video recordings where the neurologist gets a visual of the actual seizure and its clinical extent. So a lot of neurologists will look at the video and will get a clues as to where the seizure is coming from and what part of the brain. For example, in temporal lobe epilepsy, people will get an ipsilateral dystonic reaction on one side of the body and a contralateral movement of the other hand. So if somebody like Norman was looking at that, he can work out that seizure is coming from the left temporal area just by looking at the EEG. We do video EEG monitoring, as I mentioned. Invasive monitoring, I've just spent 5 hours today doing a complicated invasive monitoring case. Neuropsychology is part of the whole workup. Standard MR imaging, meaning MRI scans that Norman showed. Functional MRI imaging is MRI scans with the patient doing a particular movement which maps that movement to one particular part of the brain. So the EEG, it does give us a huge amount of information with regard to where seizures are coming from, and then it defines as to whether that seizure type is focal or whether it's generalized. So it's very, very important in terms of making a surgical decision. And video EEG monitoring is the gold standard. Medications are usually withdrawn. So this is a patient who's got difficult epilepsy. They're brought into an epilepsy monitoring unit. We want the patients to seize there in the unit, so the medication is reduced in order to promote seizures, so to highlight where the seizures are coming from. Seizures should be recorded to identify all seizure onset zones. Usually 3 to 5 seizures are recorded. Poor surgical prognosis would be cases where seizures are coming from both sides and not one discrete area which we could focus on. Our switch of seizure activity, meaning if some patient is having a lot of seizures from the left side on one occasion and then a lot of seizures from the right side on another occasion. So this is a setup with regard to a child in an epilepsy monitoring unit. You can see the video camera on the child. You can see the child is hooked up to the EEG machine, and then medication is withdrawn. It allows the child to seize. It allows the neurologist to get a visual of the seizure semiology, or the clinical manifestation of the seizure, and allows an analysis of that coincident or concurrent recording of the video semiology. So with regard to invasive electrodes, there are a number of types, subdural strips, grid and depth electrodes. These are usually done whereby surface EEG recording isn't enough, or it's not precise enough with regard to identification, or it might be that say the video EEG shows bitemporal epilepsy, meaning it's on left and the right, but it's more on the left than on the right, so you want to confirm as to whether it's more left than right. Also, with regard to diffuse areas, it might be that a particular part of that diffuse area of the brain would harbour or would generate more of an epileptogenic onset than the other areas. So you need to map and sample as to where that is. And of course, as you're doing that, then you can't just say, well, look, we're going to resect this blindly. You need to ascribe function to that part of the brain by doing brain mapping. So the relative indications, I just touched on them then: extratemporal location, divergent non-invasive data, encroachment on eloquent cortex, tuberous sclerosis and cortical dysplasia. Tuberous sclerosis is this condition where there are multiple tubers in the brain. So you look at the scan, you look at the surface EEG, you see it might be coming from the right frontal area, but when you look at the MRI scan, there might be 4 or 5 tubers in the right frontal area. So which one do you remove? So you need maybe more complicated invasive monitoring and invasive recordings for that. So this is a simple diagram of a 64 contact grid. You can see it over here. This is an invasive grid that's put in. These are smaller grids and some strips, and we also use these electrodes called depth electrodes that we can put in under image guidance. And it gives us a whole load of information, which is very, very valuable. Neuropsychology is very, very important. We do a lot of surgery on temporal lobe, so we want to know before we do that as to what the patient's memory function is. We want to know that removing the temporal lobe doesn't damage that memory function. We want to know whether the patient can tolerate it, and so on and so forth. And we do a number of tests. This is a test called the Wada test, which kind of sounds terrible. And normally I made a TV program about this a few years ago, and the term extreme test was used, which caused some anxiety. And I suppose it is an extreme test, but what it is just say, for example, this is a left-sided carotid angiogram here, and just say we're operating on this patient's left temporal lobe, and we want to know whether removing the temporal lobe will cause any memory dysfunction. So what happens is that the patient comes in and has this Wada test beforehand, which is an injection into the left carotid artery of a short-acting anesthetic agent, which just shuts down the hemisphere for a half an hour. And a neuropsychologist will test then memory function. And by testing memory function during that half an hour, they're testing the memory function of the opposite temporal lobe. So it's like a trial run as to what would happen to the patient's memory were the temporal lobe to be removed. So if the patient passes, quote unquote, the Wada test, meaning that they have a good neuropsychological profile as evidenced by the function of the opposite side, they're then a surgical candidate. You know then by going on and removing the temporal lobe on the left-hand side, they won't have any memory difficulties afterwards. So we employ this quite a bit, and it's very, very successful, and we have very, very few patients who have any memory dysfunction post-op, because the whole thing is analysed beforehand, and the patient is counseled with regard to that. With regard to imaging, it's the be-all and end-all of us. I'm afraid neurosurgery is all about scans and looking at things, and we see a number of different things on scans: mesial temporal sclerosis, cortical dysplasia, cortical dysgenesis, cavernous angiomas, a number of other things. This is a coronal image that Norman pointed out earlier on. You can see this red circle is around the left hippocampus there, which shows a white signal on this T2 weighted image, which is actually mesial temporal sclerosis, one of the most common cause of temporal lobe epilepsy. And if that patient is having seizures and they're going on for 2 and 3 years and 4 years and medication, it's a shame. It's an absolute shame. It's a crime that patient shouldn't be referred on for surgery, because it's eminently treatable with surgery. And in fact, I'll allude to later, there's a randomized controlled clinical trial from our friends in Canada which shows that surgery is much better than prolonged medication use for that. That's straightforward stuff. Norman and his team can deal with it, can work it up, it can be referred to us, and there's a 60 to 70% chance of seizure freedom with surgery for that, versus 5% with continued medical use. Functional MRI imaging, we do that, and would you believe it, there's a MEG scanner, which is one of the most sophisticated MRI machines in the world, in a university in just outside Derry town, called in McGee College. There's a functional MRI department there who look at psychology, and we've got, would you believe it, we've got free access to the MEG machine there. They normally cost 20,000 euros each, and they're only available in a couple of centres in Europe actually. Temporal lobe surgery, this is a schematic of the temporal lobe. I just want to point out a few anatomical features. This is our friend the hippocampus here. This is the anatomy of the hippocampus as it comes around on the limbic system to the mammillary bodies. We do a lot of temporal lobe surgeries. We do en bloc temporal lobectomies, we do tailored resections, selective operations, anterior temporal resections. This is again a schematic diagram. This is a schematic of a temporal lobectomy, whereby we remove the lateral temporal lobe and also the mesial structures. Mesial is just a boring Latin term for middle or towards the middle. We do a trans-sylvian selective operations on occasion, though with regard to the understanding of epileptogenesis and the various networks involved with epileptogenesis, I suppose it's fair to say that the more substantive operations are in vogue nowadays in order to try and identify and remove all of these networks. This is a post-operative MRI scan of one of our patients who's had a temporal lobectomy. You can see as you look at the scan, what's on the right side is the left side of the patient. So this is a left temporal lobectomy. So the temporal pole body, the temporal lobe, and the mesial, meaning towards the middle, structures have been removed there. This is a post-operative CT scan of one of our own patients who's had a selective operation. So it's a smaller procedure. Temporal lobe pathology, we deal with a huge amount of conditions such as tumours, gangliogliomas, vascular malformations. If I could just mention one thing, I mention it to medical students all the time. Anybody who in their adult life develops new onset epilepsy out of the blue, they need to have an MRI scan. That's just such an important thing. Cortical dysplasia, aberration of cortical proliferation. Somebody once said to us a few years ago, oh, well, temporal lobe epilepsy surgery is actually decreasing because mesotemporal sclerosis is probably less because pediatrics, in terms of febrile convulsions, is probably better managed. But actually temporal lobe surgery is actually increasing because the various conditions of cortical dysplasia are probably better identified nowadays, whereas previously they weren't, due to better MRI scans, better focus on the temporal lobe, better neurosurgical techniques, etc. So this is it. With regard to good seizure outcome for temporal lobe epilepsy, these are the kind of good indicators: clear abnormality on MRI, concordant lateralizing data, absence of status epilepticus. Good seizure control is obtained in 82% of patients for temporal lobe surgery. Limited temporal lobe resections are probably associated with better cognitive results, though all of this area with regard to the extent of the resection is very debatable, and we do hammer it out at our meetings with regard to an overall operative strategy for a particular patient. This is the study I was talking about the V-based study from the New England Journal of Medicine in 2001, where they looked at temporal lobe surgery versus patients who were managed medically with clear temporal lobe epilepsy, and the surgical group was far better. It's one of the few randomized controlled clinical trials in neurosurgery showing far better results for temporal lobe epilepsy than for prolonged medical management. With regard to diffuse pathologies, we do these quite extensive operations called hemispherectomies, whereby we remove part or all of the cerebral hemisphere. It sounds terrible, but actually it's not, when you consider the severity of the epilepsy that these conditions actually produce. Children and young adults with hundreds of seizures every day. And if you think about the underlying pathology and function of tissue, the pathology and function is that it has no function. So as I continuously say to patients and relatives, this is tissue which is functionless. It's doing nothing. In fact, it's got a negative function. It's causing seizures. Frequently, these patients already have a contralateral hemiparesis or a stroke-like effect. And the tissue that we removed, in general, in epilepsy surgery, by and large, has no function. And we don't damage people with surgery. We're very, very careful. Patients are worked up to ascribe eloquence to the surgical plan. If there's no eloquence to the surgical plan, we take that into consideration. So just a couple of conditions. This is a CT scan of a patient with a perinatal infarct, and it's large ventricle here, you can see. So this is a child with the Sturge-Weber syndrome. You can see this is the corresponding CT scan showing all of this cortical dysplasia in all of the cerebral hemisphere. This is an MRI scan of a patient with Sturge-Weber syndrome, and then also it's the corresponding CT scan. This is a hemispherectomy specimen. This is an operation of a patient with hemimesencephaly, and you can see how abnormal all of the surface of the brain there is. You can see this huge, massive cyst associated with that. And trust me, you can throw all the anticonvulsants in the world at this. They're not going to stop the epileptogenesis associated with that. This is a post-operative, at the end of the operation, and we've devised various surgical techniques in order to minimize morbidity associated with it. Corpus callosotomy, I briefly touched on that earlier on. Subpial transection. If the neurologist says, well, look, the seizure onset area is right on the motor strip, we can't remove the motor strip, because by doing that we give the patient a contralateral hemiparesis or a stroke. But what we can do is we can expose the motor strip, map it and ascribe various functions such as individual finger function to the motor strip, and make little cuts in various areas of the motor strip in order to limit the propagation of seizure activity around it. So it's actually quite effective. However, as regards this, we're actually getting better and better with motor mapping, and we've operated on a number of patients over the last few years with very discrete areas in the motor strip which previously probably wouldn't have been operated on. Vagal nerve stimulation, I wonder if I just may say very, very quickly, Dave, 2 or 3 minutes. So this is with regard to generalized epilepsy. Very, very occasionally it's done for focal, usually involving a long discussion with patients with regard to their preference. But I'd like to talk about this with regard to, because it's a very, very effective procedure in my view. It's very ill understood by the medical profession in terms of, obviously people like myself and Norman know all about it, but a lot of medical people don't, and say bad things about it when they're actually uninitiated in it. But anyway, so it's a non-destructive procedure. Basically the left vagus nerve here in your neck is this pretty rudimentary nerve which just comes out of the brain and ends up going to the spleen and the GIT in your abdomen. It doesn't do very much, does release some factors from the spleen, does control a little bit of GIT motility and so on. However, the right vagus nerve is the controlling nerve for your cardiac rhythm and your sinoatrial node in your heart. So the left vagus nerve is this kind of nerve that doesn't do very much, but gives us a pathway into the brain. So we can piggyback an electrode onto the left vagus nerve, which gives us access into various parts of the brain. So in the brain, it has this proliferation of connections, and it allows you to stimulate the left vagus. By stimulating the left vagus nerves, it allows one to connect with all parts of the brain. Sorry. The hypothalamus, the amygdala, the nucleus ambiguus, the thalamus in particular. And the thalamus is this inhibitory center in the brain in general. With regard to movement and coordination of movement, there are various positive centers, but the thalamus is an inhibitory center for movement and for other things. So by stimulating the thalamus indirectly through the vagus nerve, you get this dampening effect on seizure activity, and it also acts by releasing negative amino neurotransmitters and other agents. So it's a fantastic operation for generalized epilepsy, in my view. We quote a rule of 50s with it, in that 50% of patients will have a 50% reduction in their seizure frequency. I actually think it's probably, in fact, there's a group in New York published a couple of years ago. In fact, the figure is probably around 65%. And some patients get a huge benefit from it, and some families are delighted with its outcome. So how does it work? Chronic VNS stimulation has been shown to affect cortical blood flow and neuronal activity as assessed by PET scans. As I mentioned, it does increase the amount of negative amino neurotransmitters. These are the various components of a VNS system. You can see this is the VNS generator here, and these are the leads. This is a magnetic device that patients wear on their wrist. This is just a wand for generator transmission. This is a little kid having an operation. You can see the generator goes over the chest. That was from a few years ago, and there was a big drive to get the generator smaller, which we did. And the generator ended up being tiny, and now it's gone back the other way, in that the battery life associated with smaller generators isn't as long as bigger ones. And then this is the nerve. This is an operation. These are the electrical contacts on the vagus nerve, which are wrapped around there. One is, if you know anything about electricity and physics, there's a negative contact, positive contact, and a stabilizing device. So that's it. It's typically on 30 seconds every 5 minutes. You can see we did a study when I was working in the UK with my colleagues with regard to the efficacy, and we presented it in New York. 85% of patients and families said that the operation was worth having. 80% of patients have some improvement in their quality of life. 60% of them said it was worth over 50% improvement. Quality of life benefits are significant. Just some illustrative cases. This is a grid that we put in a patient last year, 64 contact grid over the motor area. This is a patient with an amygdala tumour that we've operated on. It's a patient with frontal focal epilepsy. This is post-resection there. And this brings us back to our little girl who we showed at the start. Her name is Laura. She's from North County Dublin. She had 100 seizures every day. She had hemimegaencephaly, which I showed earlier. We operated on her. Her mum was on TV a few years ago and said her last seizure was in the anaesthetic room, and she hasn't had any seizures since. And this is her with our former President, Mary McAleese, at a Person of the Year award. Thanks very much.